Good evening, all. We welcome to sixth session of our case-based discussion. Please, others can mute themselves. So today's discussion is about various case-based scenarios in cardiac system. Basically, it was a topic selected for cardiologist because this is unavailability. Our cardiac internist, Dr. Balkrishna, will preside this meeting. And I hope this will enlighten many of you about dealing with cardiac emergencies, which are so common and which many of us are not aware. Because of we have a cardiologist, now we are getting the awareness more. But when I am doing my PG and consultant in earlier years of my consultancy, I am not aware of this cardiac emergencies. I hope it will be useful for all of you. I'm handing over this session to Dr. Balkrishna. He's our pediatric cardiac intensivist and pediatric intensivist. So over to Dr. Balkrishna.
Good evening, everyone. Thank you, Revan. So today we will be discussing interesting case scenarios in pediatric cardiology. PPT courtesy is by Dr. Vikram sir, our pediatric cardiologist. As sir is not available, so we are doing this thing as. So we'll be going into the case-based scenarios, interesting cases we have come across. Am I audible to everyone? PowerPoint is visible.
Yes, Dr. Bala.
Okay. So this is a first child. Sorry, video is not playing. So I'll just tell the case scenario. It's a 3-month-old child who was presented to us in ER. So child was having history of cough and cold for 3 days. On clinical examination, child was having this noisy breathing, typical suprasternal and xiphisternal retractions were there, and workup breathing was there for 24 hours. And child is on examination, no fever, and saturation was 80% in room air. So what is your initial assessment or diagnosis when you see such a child in ER? So it's a 3-month-old child. As you can see, child is restless, cough and cold was there, and noisy breathing is there, and there is stridor, and there is no fever. Anyone, what is your initial diagnosis when you see such a child in ER as per the age group? No one wants to comment on this child?
Three-month-old, it would be laryngomalacia, sir.
Okay, good. So laryngomalacia is there, but still 3 months, the child is normal, right? So there was no past history. So, but it can be one of the DDs. Any other diagnosis? Can it be bronchiolitis?
Bronchiolitis, sir.
Okay, it can be bronchiolitis, it can be group. So if you don't want to, this thing you can type in the text messages also. Let it be a more interactive session so that it will be more interesting. So we have clinically examined this child. So this is the X-ray. So anyone wants to comment on the X-ray?
Cardiomegaly.
Not much of cardiomegaly. So any other changes in the lung? So basically it's a sorry. There are mild infiltrates, right, in the lung.
Capacities.
Yeah, there are mild infiltrates and this thing. So as such, the stridor was there. So our fellow doctor has taken the lateral view also to rule out any retropharyngeal abscess. But there is no airway obstruction, as you can see. So immediately what he did was he started the child on O2 because saturation is only 85% on the room air. So immediately as the child was having stridor, any other diagnosis for anyone other than bronchiolitis or laryngomalacia, when you see such a child with fever, cold, cough, stridor?
Sir, acute laryngotracheal bronchitis, sir. Steeple sinus scene.
Okay, acute LTB is one possibility which you need to keep in mind because child is restless, SATs are not maintaining. That is one possibility. So what you do is usually the same thing which we also do the same thing. We'll start the child immediately with O2. We'll start some steroids. So child was started on adrenaline and Budecort NEPs. But there was no response from the child side. So immediately we went for a blood gas. So can anyone comment on the blood gas? So how you comment on a blood gas? When you see a blood gas, usually you see
Metabolic acidosis.
Okay. Any other findings?
Increased lactate.
Okay.
SO2 is 58 only. Huh?
Sorry.
CO2 washout.
CO2 washout is not there. Still, complete, not compensatory. You can comment as such. Whenever you see a blood gas, usually you see the value whether it is normal. Between 7.35 to 7.45 is normal. If it is less than that, usually you see whether it is respiratory cause or metabolic cause. Here the PCO2s are fine. So go to the metabolic. Bicarb is 11. Definitely base deficit is -16 with lactate elevated to 6.7. So this is a case of respiratory acidosis. So with all the
Metabolic.
metabolic acidosis is there with lactate elevated. So what could be your DD now? So initially you thought it could be acute LTB, you thought it could be bronchiolitis, you thought it could be group, you thought it could be anything else. So you have started on steroids, O2, NEPs, still no response. Seeing this gas, anyone wants to comment any further diagnosis? Because we thought it is a respiratory cause, but your PCO2s are normal, right?
HB 7.7.
Yeah, but with HB8, you don't cause anemia induced CCF.
Yes.
X-ray is also not showing much of cardiomegaly. So any other diagnosis? Okay, someone responded as DKA. So this child GRBS was done, which are not mentioned. So GRBS was normal. And neonatal age group around 3 months or infant age group 3 months, DKA is quite rare. So what do you think other common cause?
Cardiac cause. Right?
Cardiac can be one cause, but why you think of cardiac here?
Lactate is
SO2
elevated.
58.2 and
So I want to comment here. The saturation of
SO2 is 58.
yeah, the saturation of 58.2%. You only comment it when you want to calculate for the oxygen extraction ratio. I don't want to go into the details of that, but usually that is a gas, that is oxygen percentage, oxygen consumption. That is a value which is given here actually. That is number is determined by oxygen extraction ratio. Usually that value, usually we take it into consideration whenever you insert a center line. Like if you insert an internal jugular line, usually it will be in the SVC. So you can comment the oxygen uptake by the SVC. So if there is any failure, you can comment on that. If the child is, the center line is in the femoral, you can call it as mixed venous oxygen saturation, MVO2. You can Google it, you'll be having better idea. I don't want to go deep into that.
Less than 5% than the normal SCO2.
Yeah, so usually this VBG, you take it in the peripheral line. So usually we don't comment on this. Whenever you do a VBG, usually we don't comment on the periphery, this thing. Whenever you take it from the center line only, you see into this value. So that's what I just want to mention here. So it could be sepsis, it could be inborn error of metabolism also, because child 3 months age group and cough, cold, respiratory viral history is followed by so followed by, you notice that the child is having the distress, stridor. So we did
what is BP of the child and any other investigation done, sir?
No, this BP of this child was having BP of 75/50. Still, it is in the compensated shock range only. So pulses are okayish, not that bad. So whenever you see in the gas, immediately what our fellow did was immediately he has given one bicarb bolus along with NS bolus because lactate was high and there is respiratory acidosis. So he suspected with this history, with the clinical backup, with all the current investigations and the clinical examination, he thought it could be sepsis or IEM, or it could be acute laryngotracheal bronchitis. So he did an echo. So actually the echo was showing, you can see here, the RA and RB are significantly dilated compared to LA and LB. In the
Thymin deficiency.
Sorry?
Thymin deficiency.
So why you think it is thymin deficiency?
RARV dilated, sir.
So why?
pH.
Okay.
And 3 months old, so mostly.
So main possibility is whenever you, usually we have this facility of doing echo here, but most of the centers, they don't have the facility of echo machine available in their own units. So initial suspicion for us has been completely ruled out after seeing the echo. The echo was showing complete dilatation of RA and RB. So that's a good point. So this child is actually exclusively breastfed child. And as someone has pointed out, it is suspected thymin deficiency induced PPHN. So immediately we have consulted our pediatric cardiologist. We have sent him the views. So immediately he told it is thymin deficiency. So we have given one stat dose of 100 mg OD. Within next 6 hours, the child responded significantly well. And we have started for pH, sildenafil. So child has improved significantly nicely. The stridor has gone away. The distress got better. The peripheries have improved. So this is the blood gas, which has been taken after 4 hours. So can anyone even comment on this blood gas?
Normal. Hemoglobin.
Yeah, HB is low. That can be because of sampling, because already HB was 7.7. You might be done blood gas and you are trying to take in some samples.
Normal ABG.
So previous ABG was showing how much?
Acidosis.
It was metabolic acidosis with lactate of 6 and bicarb of 11 and base deficit of -15. So definitely here your gas has normalized, pH of 7.43, PCO2 of 39 and PO2 of 100, and bicarb has become normalized. So you can see the difference between the past echo view and here the echo view. Can everyone appreciate this thing? So definitely you can see LA and LV are far more visible. The compression from the RA and RV to LA and LV has definitely reduced because your pulmonary artery hypertension has reduced. So your RA RV has dilatation is become less. So compression is less. So automatically the perfusion will be better. Because the perfusion is better, the lactate will be normal and your bicarb levels are also completely normalized. So usually our experience is we have managed more than like 100 cases. So with thanks to Dr. Vikram sir, our pediatric cardiologist, who was very helpful in this particular child also. So from then onwards, we have started any child who usually presented at a significantly breastfed child. Okay. So usually in our state, especially in this West Godavari and East Godavari region, the mothers will be strictly on diet regimens. So I've seen no many mothers which we ask once we diagnose this case. So usually what they tell is they will eat like only rice, dal, and morning idli. That's it. Usually they don't take anything else. So that can cause history of maternal malnutrition to be there and high lactated presentation, and there will be dramatic response to timely treatment. We have seen like at least minimum, with my experience, I have seen at least 10 cases. So I have seen like dramatic response. Usually we see it could be sepsis, IEM. So we start giving boluses, we start O2, we start NIV and all that. So by the time we do the echo and give one thiamine dose, the child response will be significant. So as you all know, thiamine is essential water-soluble vitamin. It is no endogenous source. It needs to be continuously supplied in the diet, and half-life is less than 10 days. So what will happen if there is any thiamine deficiency? There will be lack of energy, and it will cause severe pulmonary hypertension and heart failure, and there will be muscle weakness, and paralysis of GIT also will be there. So what will happen is when there is a progressive energy failure, that will cause the damage to the myocardium, and it will lead to what I said was circulatory failure. So if there is circulatory failure, definitely there will be lactic acidosis. And I was pointing out RA, RV and compressing the LV, which leads to LV dysfunction. And other mechanism is reactive oxygen species, which actually vasodilate. So what are the dietary practices which you see in postpartum mothers? As I was commonly pointing out, in Telugu, usually you call it as patyam. So if you ask any parents, whoever you see such babies, so most of the time they will tell, as I was pointing out, it is only common breakfast. Pulses and cereals were not permitted. They usually take rice with rasam and a few selected vegetables. No other animal proteins were permitted. And evening time, if you ask the history, again they will tell they'll just have a cup of tea with biscuits. So usually the food restriction usually lasts for 3 months for male babies and 1 month for female babies. That is when usually you see most thiamine deficiency in the male babies. So as you see clinical symptoms, fast breathing, vomiting, and change in the voice, because I was training you, it will cause paralysis in the GIT. So that will lead to vomiting. And along with the change in the voice, fast breathing, and hoarseness of voice is because of the recurrent laryngeal nerve palsy caused by the compression from the dilated PA or by dilated involvement because of cardiomegaly. So signs will be tachycardia, tachypnea. And investigations wise, you don't see much. If you signs of pulmonary hypertension, usually the lung will not be plethoric, it will be algemic. So echo, if you see the RAR will be dilated. The other point is lactic acidosis. So treatment, oxygen therapy, IV thiamine 100 mg dilute in 10 ml of normal saline, usually given as infusion over 1 hour. Usually give it once a day for 3 days for all babies, and oral thiamine was prescribed at 25 mg for infants. And most important thing is you need to prescribe for mothers also. Usually we have this habit of treating only for the babies. So you have to prescribe for the mother also. You need to give 100 mg for mothers once a day for 3 months. And other pulmonary vasodilators depending upon the severity. So long-term side effects will be very bad. There will be marked intellectual and motor disabilities. microcephaly convulsions, and various degrees of heart block. And chronic subclinical thiamine deficiency will be subtle neurological impairments like abnormalities in cognitive and psychomotor development and in language acquirement and also convulsions. So be very careful. So it's a very common problem, but it is underdiagnosed, fatal if not treated early. It is very, very easily treatable and it needs awareness in the medical community. After that, usually we started asking and we found so many mothers have been telling that the mother is on Pathyam. So when you see such a history, when you see someone who is having cough, cold, stridor, keep one possibility of beriberi also in your mind along with ALTB, bronchiolitis and other causes. So this is the next child going into case 2. So 3-month-old male child, 5.5 kgs, fever for 2 days. We are treated with paracetamol for 2 days. So fever, cough, cold, diagnosed as URTA. The child was started obviously on augmentin and on examination macular rash, otherwise clinically stable. So fever was continued. Antibiotics has been changed to azithromycin for 3 days because still fever was there, cough and cold is the usually the pediatrician suspected it could be any viral fever. So macular rash has been disappeared. Then child has developed dry and red lips and red eyes for 2 days. And child was actually completely afebrile once the child has been started azithromycin. So what do you think here your possibilities are? When you see someone across?
Kawasaki.
Sorry?
Kawasaki.
Okay. Right away you want to think Kawasaki or?
Anathema, viral anathema.
So whenever you see fever with rash, how you approach any child with fever with rash?
The type of rash.
So you want to see whether what type of rash it is, right? So either it is maculopapular or macular, or it is exanthematous rash, or is it associated with itching or it is not itching, right? So here this particular child, everything was fine and he was afebrile for 4 days. So again, after 4 days, the child had fever restarted. So usually what is our suspicion? The child stayed in hospital. So we sent urine routine. So urine routine was showing high white cell count and protein. So you're suspecting UTI. The child was started on IV peptides and emic acid. Child got slightly better, but still the fever was continued. And loose stools were there for 6 to 7 days. So our diagnosis has been changed there. We thought it could be enteric fever, the peripheral pediatrician. So here what could be your diagnosis? Because here initially we thought it could be any URTA, then we kind of changed it to added azithromycin, but there was rash which came and it disappeared later. But again, sorry?
Fever of unknown origin.
Hello, sorry?
PUO, sir.
Okay, PUO can be one possibility. But here afebrile was there, right? The child was in between afebrile. Here the child having fever continued and he was afebrile for 5 days, again the fever restarted. So this is a new onset fever.
Missy.
So Missy could be one possibility. PO also can be one possibility. Any other?
Hospital acquired.
Okay.
Enteric to one positive.
So it's after that the child has been referred to tertiary center. Sorry. So child was started on IV peptides and monosep. Child was irritable and crying. So heart rate was more than 220. So suspected SVT, child was referred to us. So of course in our hospital on examination, child was febrile, no rash, no lymphadenopathy, no pallor, no edema, normal conjunctiva, respiratory size, it was clear, no respiratory distress, BP was normal, normal heart sounds. There's mild hepatomegaly, no splenomegaly, soft abdomen. Child was alert but irritable and but consolable. And regarding the heart rate of 220, so child was febrile, so we have given an IV paracetamol dose. So the heart rate decreased to 180. So 12 ECG has been done. As you see, all the waves containing P waves are there. So definitely it is not a SVT, right?
Sinus type.
Viral myocarditis.
Okay, viral myocarditis can be one possibility, but child was not having any signs of failure. So child is having normal breath sounds.
BP is normal.
Sorry?
BP is normal for the days.
Yeah. BP is also normal. There is no shock, normal heart sounds. So what do you want to think now at this stage? So fever initially treated as UTI, then URTA, then added along UTI, then still fevers are persistent. So child was referred to here in SVT. But on clinical examination, everything was normal.
Like to get 2D echo and ultrasound done, sir. Look for any serious collections.
Sorry, any? You're correct, sir. But why you want to do 2D echo and ultrasound for this particular child? So how do you want to approach this child? So still the child is febrile. It's almost like in between afebrile period, but it was almost lasting for near to 10 to 12 days.
Atypical Kawasaki.
Okay, atypical Kawasaki can be one possibility. So somebody asked about the platelet count. Platelet counts are normal, sir.
ESR CRP.
Okay, so workup has been done. Ultrasound unremarkable. So we thought it could be Missy also, as you pointed out. So we have done that also. And as such, at that time it could be COVID. So during that time we have done COVID PCR antigen antibody, both negative. For parents also it was negative. So LFTs and RFTs all are unremarkable. Chest X-ray we have done, no abnormalities. As such, urine was showing glucosides, and we thought it could be UTI. Urine culture has been sent. Urine culture is also negative. Blood culture is sterile. Blood culture is sterile. We have done all the fever workup. Usually we send when the history of fever is there. So if you're suspecting PUO, usually it can be scrub typhus. So we send site typhus, Vidal, everything is negative.
Look for any hidden abscess.
Okay, so as someone has pointed out, initially, as you go back to the history, so whenever you suspect fever with rash, don't take it lightly. Someone has pointed out atypical Kawasaki. Sir, can you tell why you suspected atypical Kawasaki in this particular child?
Fever of 5 days, more than
high grade
5 days.
fevers, rised CRPs.
Okay.
And platelet count is normal in both atypical or.
Okay, so this child was having actually conjunctivitis, redness of lips and all, and then rash. With all the other features are negative. But you need to, one point is like whenever you see such a kids with rash, typically you can't see every child having the typical Kawasaki features. So sometimes you need to suspect of atypical Kawasaki also. So we got a echocardiography. We did the echo. So our pediatric cardiologist Vikram sir has done this, and he has you can see the brightness around the left anterior descending artery and around the circumflex artery.
Dilated.
And your coronary arteries is dilated, your right coronary artery. So management, IVAG we are given 2 gram per kg, methylprednisolone. The fevers have subsided after you are giving IVAG and methylpred. So child was started on oral warfarin. Obviously, you stopped IV antibiotics after negative cultures, and child was discharged after optimizing your anticoagulant doses. So lab data, So initial CRP was 4.8. As you can see here, with all the markers, initial ESR was 60. As you can see, NT-proBNP was highly elevated around 8, and the other markers are fine. Initial markers were high, but later, once we started giving the IVIG, definite improvement was there in the marker level. So D-dimer has started decreasing from 2700 to 547. The ferritin started decreasing. LDH is also decreasing. The differentiating feature between this thing is like if you're suspecting MISC, your CRP will be quite high. And you can see here there is thrombocytosis. Initial platelets are all normal. The next day the platelets were 11 lakh 2000. So main thing, what went wrong here? There was delay in the diagnosis because the skin rash was actually attributed to the adverse drug reaction. Main thing is like there was cracked lips and red eyes which are completely missed, and there was sterile pyuria.
Normal.
Now what will happen if you don't do the diagnosis? The 3 months old with extensive coronary aneurysm, there is lifelong risk of MI, cardiac failure, and there is lifelong anticoagulation. So could it have been prevented? Definitely yes, because I have seen 3 to 4 people commenting it as atypical Kawasaki. Yes. So you need to have with high index of suspicion.
Sir, one doubt.
Yeah, please.
Sir, is it mandatory to give both methylprednisolone and IVIG compulsory, sir?
Yeah,
Both.
because the child was having coronary artery aneurysm. There was
Okay.
cardiac involvement. That is the reason we are given here. Otherwise, your IVIG would be sufficient.
So what is the cutoff, sir? More than 3 standard deviation or to give both? Is there any more than 10 like this? Any values?
Usually, you see the coronary Z score. After that, only usually we comment on this. So coronary Z score, usually our pediatric cardiologist will calculate and tell us the score. Accordingly, we will give that.
Yes, sir. More than how much you have to give both, sir? If it is a bit more than 10, you have to give both, or between how much like this? Is there any arbitrary value like this, sir?
I'll just find out and tell you. Okay.
Okay, sir. Thank you, sir.
Thank you. So this is another child. It's a 2-month-old child with. This is actually case courtesy actually from Deepthi ma'am from Bhimavaram. So it's a 2-month-old child with history of fever for 4 days, and child throat a seizure on 3rd day. So they have done the CSF analysis. Definitely suspected it could be meningitis. So child was picture was showing like high lymphocytes and protein and low glucose, typical meningoencephalitis kind of picture. So, but even though treating of antibiotics also, child was having still high grade fever spikes. So what is this sign here? Can anybody make out?
Reactivation of BCG.
Yeah. Reactivation of BCG scar.
Kawasaki.
So main thing is like this particular child is actually diagnosed as Kawasaki. Why? Because we have seen like 3 to 4 cases where definitely there will be reactivation of BCG scar. And you can see the typical perianal excoriation. So child has been started on immunoglobulins, IVIG. The coronaries are normal. So Kawasaki disease is a common medium vessel systemic vasculitis in small children. Etiology is not known. Usually it poses several challenges. Even for us also, sometimes we take so much thinking whether it is incomplete or it is atypical Kawasaki. As such, we have seen last 3 cases, there is no specific lab test. It is entirely based on clinical features. One child was having the sterile pyuria, fever was there, rash was there. After that, rash was completely subsided. This particular child, we thought it could be meningoencephalitis. We did everything. The antibiotics have started, but still the fevers were not subsided. So one catchy point was the perianal excoriation and reactivation of BCG scar. So the features are very, very non-specific and they overlap with other infectious disease. So as per the guidelines, fever persisting for at least 5 days without any other explanation, plus 4 out of the following 5 criteria. So one is bilateral non-suppurative conjunctivitis, cervical lymphadenopathy after more than 1.5 centimeter, polymorphous rash, non-specific maculopapular eruption, and change in lips or oral mucosa, any red cracked lips or strawberry tongue or diffuse erythema of oral mucosa. And usually you see in these extremities, but I have seen very less cases where you see this peeling of skin and all. Why? Because usually it is seen in week 2 or 3. So usually most commonly you will see this redness of lips and it will be non-suppurative conjunctivitis. These two are the most common features which you actually see along with rash. So you need to have high index of suspicion. That is the main point here. So you can see here, red clacked lips, diffuse erythema of oral mucosa, strawberry tongue, polymorphous rash. So initial stage, there will be erythema and edema of palms and soles. There will be no diffuse peeling. So peeling will be seen in week 2 and 3. So initial stage, it will be only erythema and edema. So incomplete Kawasaki disease, it is usually more common in infants less than 6 months, and presence of fever and less than 4 principal this thing. So fever and excessive irritability may only be the manifestation, and not all clinical features of Kawasaki may be apparent at a given time. Some of the features may already have subsided, hence one should carefully observe and ask for signs and symptoms. So incomplete Kawasaki disease is most commonly seen in infants, and it is associated with development of coronary artery aneurysms. So this particular child, we had this fever, irritability, and meningitis signs. So what is atypical Kawasaki? It can be seizure, stroke, meningitis, arthritis, pneumonia. So usually infants may present more commonly with atypical features, and they have increased predilection for coronary artery aneurysm. So main point of discussion here is have a high index of suspicion when you have a fever for 5 days, along with any redness, or along with if you see any rash, or erythema, or redness of palms and soles, along with cervical lymphadenopathy. So have a high index of suspicion. And one more thing is, the main point is perianal peeling with erythema. Usually it will occur few days before the appearance of periingual desquamation. So the last sign will be your periingual desquamation. So this case actually you're able to diagnose that particular child with meningitis because only with the reappearance of BCG scar along with your perianal excoriation. So what are the other indications of Kawasaki disease? Reactivation of BCG site, sterile pyuria, peripheral arthritis, CSF pleocytosis, and extreme irritability out of proportion to the fever. So learning points, always suspect Kawasaki children in Kawasaki disease in children with PUO, febrile illness not responding to routine treatment. Late diagnosis have serious implications. Beware of incomplete Kawasaki disease, atypical Kawasaki disease, especially in the young infants. Not all features of Kawasaki will be present at the time of infection. So beware of other features as clearly mentioning out. There can be sterile pyuria, CSF pleocytosis, meatal inflammation in boys, and erythema and duration of BCG scars and gallbladder hydrops. So this is another child, 9 years old male child with multiple joint pains for 20 days, small joints of hands and feet, and there is back pain. So family history of similar complaints was there with his elder sister. So definitely they are treated as juvenile idiopathic arthritis. So child was referred to rheumatologist. ESR has been raised at the rheumatoid factor ANR negative. Started on naproxen, no improvement at all. So what do you think when you come across such a child? Anyone wants to comment?
Rheumatic arthritis.
Just right away you want to point it as rheumatic arthritis. Rheumatoid factor is negative, right? They have done because it was shown to the rheumatologist, rheumatoid factor and ANA both are negative. So it was seen by referred pediatrician. Another, so he got the history of fever and cold was there 1 week before the onset of joint pains. And clinical examination, there was a pansystolic murmur. He requested echo. So ASO titers and has been done, which is more than 5,000. So what is your diagnosis now?
Rheumatic fever, arthritis.
Yeah, it could be rheumatic heart disease. So there was severe MR was there. So child was started on steroids, high dose aspirin, there was a good response. The repeat echo which was done, the MR has been definitely reduced and there is good improvement. So acute rheumatic fever. So what are the typical features of arthritis? There will be migratory polyarthritis involving the large joints of limbs. Onset is there 2 to 3 weeks after streptococcal infection. Usually they respond well to the use of salicylates such as aspirin. So without treatment, usually arthritis will last from 2 to 5 days in each joint. So what are the atypical features? Joint involvement may be mono rather than polyarticular. It is additive rather than migratory, involving small joints of hands and feet. And Jones criteria didn't mention these typical features. So going into the next case, this is the last case. So it's a term child, no antenatal concerns. So obviously the child was discharged after 48 hours. So on day 7, child was having 1 day of history of feeding difficulties. So sudden deterioration, the child collapsed. So what do you see usually when you come across such a child? So child was well-being, normal child, which was discharged at home, 1 day of feeding difficulties, and there was sudden deterioration. So what will be your initial DD when you see such a child in ER?
Cardiac
TAP.
duct dependent circulations was lost.
Why you think duct dependent circulation?
On day 3 PTA closeness.
TAP.
Okay, TAPD can be one possibility. Duct dependent cyanotic heart disease can be one possibility. Okay, any other?
Inborn errors of metabolism.
I am too early to comment because it's just 1 week. More common?
Aspiration.
Sorry?
Aspiration.
Aspiration pneumonia can be one possibility because there was feeding difficulties. Child might have aspirated, suddenly lead to deterioration and shock. Okay, any other? Can it be sepsis and septic shock?
Yes, sir.
Right? It's more common, right?
Yes, sir.
Rather than your PDA closing and your duct dependent and this thing. So aspiration pneumonia and septic shock are more common possibilities, right?
Yes, sir.
So initial assessment and management, ABC. So secure the airway, breathing, ventilatory support if needed. Definitely the child was in shock. So fluids has been given. So GRBS has been done. The GRBS is around 85. So immediately in the ER itself, when the child was in collapsed state, the heart rate was 180. The respiratory rate was around 70 per 80 per minute. The child was having retractions, pale, shock. So immediately we secured the airway. We have given fluid boluses, start on inotrope. So differential diagnosis, it could be sepsis, aspiration pneumonia query. As someone has nicely pointed out, it could be critical congenital heart disease. That is one most important point because child is well thriving, normal, home when child with just history of feeding difficulties suddenly comes to you in a collapsed state. So you need to suspect of left heart obstructive lesions. And it could be IEM as someone has pointed out. So when do you suspect the cardiac problem? If you see a heart murmur or feeble femoral pulses, usually we don't tend to see the lower limb pulses whenever we are discharging a neonate. When I have that habit, you see the clinical color, the child is pink colored, right? Do you have the habit of checking lower limb pulses?
Yes, sir.
No.
Yes.
When I see the color, I think like, okay, baby is pink colored, active, warm. I'll just write Crichton activity good. The child
Coact.
Sorry?
Yes, sir. Coact may be the.
Yeah, coactation, you need to have one more possibility. So you need to see for differential cyanosis.
SpO2 pass test.
Sorry?
SpO2 test, sir.
Yeah, you need to do that also. So usually whenever you suspect a cardiac problem, if you give oxygen for 5 minutes, after that, if you see the PaO2 definite difference, if the PaO2 goes up to 225, then it's not a cyanotic heart disease. If it is less than that, you can suspect cyanotic heart disease. But you need to, when do you suspect a cardiac problem? If you have heart murmur, feeble femoral pulses, and upper limb and lower limb BP difference, differential cyanosis. So what could be your DD now? So now you are suspecting could be cardiac.
What is the pulse?
So lower limb pulses are feeble, upper limb pulses are okay.
Coactive.
So coactation of aorta.
Hypoplastic left.
Hypoplastic left heart syndrome.
Okay.
Interrupted aortic arch.
Interrupted aortic arch also can be one possibility. So critical aortic stenosis, coactation of aorta, interrupted aortic arch, hypoplastic left heart syndrome. So usually what you stabilize the child is whenever you suspect a cardiac problem, usually start prostin, because that is the only life-saving drug which keeps your PDA open. So dose is 5 to 100 nanogram per kg per minute. The half-life is only 1 minute. So clinical response usually can be seen within 15 minutes actually. So usually use it for stabilization and bridge to corrective surgery. So common side effects are usually apnea. We have seen very less cases. Usually we went until maximum of 20-25 nanograms. Usually in such cases also I have not seen any apnea. Usually we see flushing. There will be hypotension. If you go until more than 25 nanograms, usually we have seen features of shock, irritability and jerky movements. So early diagnosis, don't completely rely on your TIFA scans. Comprehensive neonatal cardiac screening. This is the most important point. So usually when you see a neonate, you tend to make, okay, color, everything is good, discharge. So usually don't put a steth and listen to the murmur. You don't tend to see the upper limb and lower limb saturation, pulses, BP difference. That is, even I have the habit still now, even if I'm telling you this. So usually the neonate, we don't tend to do all this. So usually we see everything is fine, discharge. So this is the most important point. So check for the lower limb pulses, look for differential cyanosis and pre and post ductal saturation, and look for murmur. So you can see here initial, actually the video is not playable. So initially here the down paper saturation of 80, 72. So once we started, it increased to 97, everything was fine. Thank you, everyone.
Good case discussion, Dr. Bala.
Sorry. So I'll conclude this session. Anyone having doubts?
One more case.
No, actually, that due to the time frame, I need to end this session here. So any doubts?
Sir, is it mandatory to intubate neonate before giving prostaglandin?
Not necessary. If the child is in like bad shock, in this particular case, the child was in shock. But usually, if you suspect a cardiac problem in the initial stages only, if you start prostin, we have seen response. Not all cases we have intubated. If the child is in a complete collapsed state, we have intubated, but not all of them we have intubated. I have seen dramatic response in 3 to 4 kids, I mean neonates, after starting prostin. I just waited for 10 minutes. Usually we will be like tensed, but as such, we have the option of pediatric cardiologist available with us, Vikram. So when we started, we have seen the dramatic response.
Enoxaparin till how much? In Kawasaki, enoxaparin till how many days you are taking, sir? Is it any protocol guidelines are there, sir?
Yeah, guidelines are there. I'll share it in the group.
Yes, sir. Thank you.
Thank you. Okay. Thank you, everyone. Thank you for joining this wonderful session.
Thank you, Dr. Balakrishna Reddy.
Thank you.
Nice.
Thank you. So I'd like to conclude this meeting. Thank you.